Hello everybody, myself Dr. Naimish, second year gynec resident, going to present on HELP syndrome. First, objectives are to find out incidence of HELP syndrome in preeclampsia, eclampsia and its overall incidence. Second, to analyze the clinical profile of HELP syndrome. Third, to study maternal and perinatal outcome including morbidity and mortality. The acronym HELP was coined by Weinstein in 1982. It is a syndrome that is characterized by preeclampsia, hepatic endothelial disruption, platelet activation, aggregation, and consumption, resulting in microangiopathic hemolysis, ischemia, and hepatocyte death. It occurs due to incomplete trophoblastic invasion of spiral arteries. As a result, it releases anti-angiogenic factors, which is antagonist to VEGF and PGF. Ultimately, inflammatory pathway gets activated, which causes endothelial destruction, which activates coagulation pathway. Prevalence ranges from 0.2% to 0.6% in all the pregnancies and 10 to 20% in patients with preeclampsia. It typically occurs between 27 weeks of gestation and delivery and immediate postpartum in 15 to 30% of cases. Risk factors are primary gravida, overweight, previous history of preeclampsia, white race, history of HELP in previous pregnancy, maternal age more than 35 years, history of poor pregnancy outcome, and chronic hypertension. Material and method. A retrospective study was conducted from July 2017 to September 2019 at a tertiary care center. 40 patients was taken for HELP syndrome in pregnancy to study fetal-maternal outcome. Informed consent was taken from the patient and detailed history was taken including gestational age, history of poor pregnancy outcome, history of HELP syndrome or preeclampsia or eclampsia in previous pregnancies. Necessary investigations were carried out like CBC with peripheral smear, coagulation profile, D-dimer, LDH levels, ALT and AST levels, and history of other parameters were also taken, that how mode of delivery, blood components, maternal and neonatal complication in previous pregnancy, there was any neonatal intensive care admissions or not. Inclusion criteria includes three main things to be studied, that is evidence of intravascular hemolysis, elevated liver enzymes and low platelet counts. Evidence of intravascular hemolysis was diagnosed by following factors like abnormal peripheral blood smear, elevated lactate dehydrogenase levels, that is LDH greater than 600 IU per liter, elevated bilirubin level or bilirubin level greater than 1.2 mg per dl, elevated liver enzymes like aspartate aminotransferase, that is greater than 70 international unit per liter, LDH greater than 600 international unit per liter, and low platelet count, that is platelet count less than or equal to 1 lakh. Tenesis classifications, that is according to this classification the following criteria should be fulfilled, that is platelet count should be less than or equal to 1 lakh, AST or LT levels should be 70 international per liter or more, LDH level of 600 international unit per liter, or bilirubin should be more than 1.2 mg per dl or more with abnormal peripheral smear. This is the Mississippi triple class system, which is based on platelets, AST or LT levels, severe, moderate, mild. Result: total 21,118 women delivered during this time period. Study shows that 0.19% incidence of HELP syndrome in total deliveries and 23% incidence of HELP syndrome in preeclampsia and eclampsia. Studies also showed that disease is more common among new case rather than registered case. Regular follow-up reduced the PIH, eclampsia and preeclampsia, and finally the HELP syndrome. The study shows that HELP syndrome is most common in age group of 20 to 25 years, which is similar to Lakshmi Natal study, which shows the 60% of incidence of HELP syndrome in age group of 20 to 25 years. The study shows that HELP syndrome is more common in primary gravida patients, which is as compared to multigravida patient, which is comparable with study done by Durugar et al. In 2017, which shows that 70.5% patient of HELP syndrome presenting with primary parity. Present study shows that Mississippi class 2 contains maximum number of cases, that is 45%, which is comparable study done by Lakshmi and Narayan et al., which also shows that maximum cases falls under class 2 in Mississippi classification. Mode of delivery in my present study, which is comparable to other study. In present study, 67.5% patients were delivered by caesarean section, while 32.5% patients delivered by vaginal. This is comparable to study conducted by another two, that is Preetha George and VM Jayasri Thanachi et al., which shows that 74.5% patient delivered by caesarean section and 25.4% patient delivered by vaginal. Amrit Pal Kaur et al. In 2018 shows that 57.8% patient delivered by cesarean section and 42.2% patient delivered vaginally. Hemoglobin level in patient with HELLP syndrome. Platelet count in patient with HELLP syndrome. Maternal complications, they are placental abruption, DIC, eclampsia, acute renal failure, pulmonary edema, PPH, MOS, death. Neonatal complications are prematurity, RDS, IUGR, IUD, and neonatal death. Discussion. The results of the present study shows that 62.5% of patients were unregistered and it was more common in 20 to 25 years age group, accounting about 45%. Primary gravida patients have more chances to develop this disease and mean gestational age at the time of diagnosis was 36 weeks. In our study, most cases were falling in class 2 of Mississippi classification, that is 45%, and 87.5% cases were of complete HELLP syndrome according to Tennessee classification. 13 had vaginal deliveries and 27 patients underwent LSCS, that is cesarean section, being most common mode of termination in HELLP syndrome. Intrauterine death and prematurity were most common complications associated with our study. Perinatal death occurred in 3 cases, that is 7.5%. Eclampsia, where in case where there is an eclampsia, 4 doses of Maxel was given, and after stabilization, they had undergone induction of labor. All the patients with PPH were managed conservatively with uterotonics and blood transfusions. In our study, transfusion rate was higher because most of patients with HELLP syndrome were belonged to lower socioeconomic class and were anemic. Patients with pulmonary edema and MODS required ICU admissions and ventilator support. Maternal mortality occurred in 3 cases, that is 7.5%, showing HELLP syndrome to be a very fatal disease in pregnancy. Conclusion. The study suggests that all the patients with hypertension should be screened and should have a complete blood count, platelet count, and liver function test. Once diagnosis of HELLP syndrome has been made, it warrants aggressive intervention with control of blood pressure, anti-seizure prophylaxis, corticosteroid treatment for fetal lung maturity, and expeditious delivery. In our study, most of the patients required blood component, that is 82.5% transfusions had occurred, and the patient with organ failure required ICU support or had the hemodialysis. So patient diagnosed with HELLP syndrome should be managed at a tertiary care center where all the medical facilities are available. Thus, an early diagnosis and early initiation of treatment significantly helps in improving maternal morbidity and mortality of patients with HELLP syndrome. Thank you.